Hello, my name is Vincent SOBANSKI and I am working at the Department of Internal Medicine and Clinical Immunology at the Leeds University Hospital, and I would like to welcome you to this presentation about pregnancy in systemic sclerosis. So first of all, I would like to give some introduction about systemic sclerosis, which is a systemic disease characterized by a skin thickening due to the deposition of matrix extracellular deposition in the skin, as you can see in these pictures. I am not going to talk in this presentation about localized sclerosis, also called morphea. And the prevalence of systemic sclerosis has been estimated between 30 and 120 cases per million inhabitants, which is in France about 6,000 and 9,000 cases. We have 3 to 8 women for 1 male patient. Systemic sclerosis is an heterogeneous disease. We have 3 main pillars in the pathophysiology, which are fibrosis, vascular involvement, and autoimmunity, but we can observe a very various clinical presentation in patients with heterogeneity in organ involvement. First, we are going to talk about fertility of systemic sclerosis patients and data on pregnancies. This is a relevant question because the sex ratio is 9:1. The mean age at diagnosis is 45 years, and we can observe an older age at conception in our time. However, evaluating fertility and pregnancy outcomes is difficult, because there is several factors that can influence those fertility and pregnancy outcomes, which are psychosocial environment, mother age at conception, physical condition that can limit sexual activity. There is an influence of systemic sclerosis on pregnancy, an influence of pregnancy on systemic sclerosis, and also there is an influence of medical care of the patient. Regarding sexual activity, we have a few data, but we know that scleroderma can induce physical changes, exercise limitation, and functional impairments. And in this study in 2009, 101 patients have been asked about their sexual activity, and 59% of them were sexually active. We can observe that inactive patients were older, about 10 years. We can also notice that systemic sclerosis was the reason in 17% of patients to be sexually inactive. And we can see in the list on the right panel that the scleroderma-related problems were mainly pain or fatigue and depression, some medication, or dryness of the mouth or vaginal dryness. There are methodological limitations in the evaluation of fertility in systemic sclerosis, in particular because there is a lack of precise data before and after disease onset. In some studies, we can observe that the mean delay before conception is superior to healthy subjects, and that the fertility rate of scleroderma might be inferior to healthy individuals, but seems similar in the first studies to those with primary Raynaud's. There is a question whether the potential factors of infertility have been collected, and in this study in 1999, we can see that there is 3 columns: patient with scleroderma, patient with rheumatoid arthritis, and normal controls. And we can see that patients who have never been pregnant are 20% in scleroderma and RA groups versus 12% in normal controls. However, there is patients that are unable to become pregnant for 1 year. There are 15% in 3 groups, and the overall successful pregnancy is comparable, is between 37 and 43% in all groups. And we can see in the list that there are different factors that can influence fertility, which is the familial status and the health status of the partner. In this recent study in a Chinese group published in Rheumatology. We can see in 342 patients with scleroderma the situation before disease onset and after disease onset. We can see before disease onset that more than 200 patients had intention to have children, and all of them tried to conceive, and more than 200 of them had a successful pregnancy, and the infertility was present in 9 patients. Regarding patients after disease onset, 91 patients had intention to have children, and we can notice here that more than 200 of them had no intention to have children. 69 of patients tried to conceive, and we can observe again that 22 did not attempt to conceive. And finally, 61 patients had a successful pregnancy, and the infertility was present in 8 patients at the end. So there is methodological limitation due to retrospective studies and/or based on questionnaire, that the obstetric terminology is different according to time or country. The period of study is crucial, whether this is before or after scleroderma onset or both, and also how were the estimates calculated. Were they calculated in all patients, in fertile patients, or in all pregnancies? When we look at miscarriage or spontaneous abortion, we can see that we have very heterogeneous definition in the different studies. Some of them will give a week of gestation in the definition, but some of them did not. However, we can notice that the global rate of miscarriage is around 12 and 15%. In the general population, this rate is 11%, but 20% at 35 years, 40% at 40 years, and 80% at 45 years. We have recent data, and especially in a systematic review and meta-analysis of an Italian group, where we can observe that the risk of miscarriage is significantly higher in systemic sclerosis patients than in control. However, we can see that this risk is due to an whole study, the study of Giordano, and that surprisingly, in the Taraborelli study, no miscarriage have been described in control. But when we look at this study, published in 2012, the authors wrote that they calculated the prevalence of miscarriage with data from the literature, because the data from this population was missing in the work. So probably there is some miscarriage in control, and the number is probably not 0. So we can see that the miscarriage rate is probably similar or close to the general population, but we have conflicting data. There might be a risk in diffuse cutaneous patients and/or advanced disease, but we need more studies. And the study in PRESS-2, that will be the new study of the Taraborelli team, should be published soon. Regarding placenta, there are few studies that have been describing the histopathological changes, and we can observe that there is a decidual vasculopathy in placenta of patients with systemic sclerosis. Interestingly, in a recent study, we can see that there is inflammatory infiltrate, as shown on the right panel, with CD3, CD11, and CD68 staining, and that there is higher staining of several factors, such as CCL5, that can suggest inflammatory and especially macrophages involvement in those patients. Regarding intrauterine growth restriction, we can see that the rate is probably superior to the general population, even if the data is lacking. And this highlights the need of ultrasonography monitoring in those patients. The preterm birth rate is also higher in systemic sclerosis patients, between 11 and 40% versus 11% in the worldwide population, but it is very dependent of the socioeconomic status of patients. And as a comparison, in the PROMISE study with patients followed for systemic lupus erythematosus or antiphospholipid syndrome, the rate was 9%. Finally, regarding the perinatal death, this risk is higher also in systemic sclerosis than in controls. In the recent data, and especially in the meta-analysis of Blachowicz, we can see that the intrauterine growth restriction is higher in systemic sclerosis patients, and we have similar results for low birth rate, premature delivery, but the risk of preeclampsia was not significant. We have also data using international classification of diseases in different healthcare systems. Here in California, where we can see that there is a higher risk ratio for preterm birth in different autoimmune disease patients, and especially systemic sclerosis. And in this study, in using the National Inpatient Sample Database in the US, we can see that there is more than 3,000 admissions for deliveries in systemic sclerosis patients and 100 times controls. And we can see that there is an association of systemic sclerosis with fetal death, cesarean section, preterm delivery, hypertensive disorders, and intrauterine growth restriction risks. However, these temporal trends tend to decrease regarding fetal deaths, which is a good news, between 2005 to 2012 and 2017. There was no difference in temporal trends regarding length of stay, cesarean section, preterm delivery, hypertensive disorders, and intrauterine growth restriction. Now we are going to look at data regarding patient trajectories during pregnancy. So the influence of pregnancy on systemic sclerosis has been described in several studies, especially with STEAN, retrospective and prospective studies, and in another study from Sampaio-Barros, where we can see that the disease is globally stable in most of patients. Some patients will present improving of the disease and some will have worsening, especially patients with lung, heart, or renal previous involvement. There is a recent study from the Canadian Scleroderma Research Group that showed that having more than one pregnancy after a diagnosis of systemic sclerosis did not significantly impact renal, respiratory, or global function over 10 years of follow-up. Some recent data regarding the systematic review of Blachowicz in 2020 show here that we have two columns, systemic sclerosis worsening and systemic sclerosis improvement during pregnancy or postpartum, and we can observe that globally patients are stable and we have more patients that will improve, especially in the vasculopathy, peripheral vasculopathy and the Raynaud phenomenon, and with the skin during the pregnancy or at postpartum. There was no difference regarding the other organ involvement due to the lack of data. Finally, in this section, we are going to discuss how to manage systemic sclerosis during pregnancy. First, we can notice that there is a lot of physiological changes during normal pregnancy, and they are significant. As you can see here, the blood volume will increase by 50% during pregnancy, the heart rate will increase, the cardiac output will increase by 30 to 50% by the end of the first trimester, and will still increase during the peripartum period. So we will have to see the patient during a visit before pregnancy, and that should be a dedicated visit where we will evaluate the underlying risk of evolution as shown by the diffuse cutaneous subset, disease duration less than 4 years, some antibodies such as anti-SL70 or topoisomerase 1, anti-RNA polymerase 3, and some other antibodies that can be of interest for the pregnancy evolution, such as anti-SSA or antiphospholipid antibodies. We will also look at organ involvement and update the cardiac echo and pulmonary function test of the patient. We will review the drug list as described in the different guidelines, especially the EULAR ones, and we will introduce folates, vaccine the patients, and we might use aspirin in some cases. During this visit, we will review the list, and here you have a practical list in this paper where we can see treatment that are forbidden during pregnancy: mycophenolate mofetil, methotrexate, bosentan, and macitentan. Some of them can be used in some cases, especially in renal crisis, but should be avoided during the other pregnancies. And some can be used during pregnancy, such as nifedipine, proton pump inhibitors, histamine blockers, steroids at the lowest dose possible, low-dose aspirin when needed, folic acid is recommended, and hydroxychloroquine is not contraindicated. We will have to evaluate cardiopulmonary function, and pregnancy is generally contraindicated if the forced vital capacity is less than 50%. We will follow the pulmonary function test and blood oxygen saturation, and we will not hesitate to introduce oxygen if needed. Regarding heart involvement, because of the significant increase of cardiac output during the pregnancy, we will contraindicate if the patient has dyspnea with a functional class of 3 or 4 according to the New York American Association of Heart, and or a left ventricular ejection fraction less than 40%. In case of pulmonary hypertension, even if there are some cases of successful pregnancy in patients with PAH, because of new drugs, better prognostics, the mortality remains high, and according to the most recent guidelines, the pregnancy should be avoided, and the clinician should advise against becoming pregnant in a patient with PAH. And some drugs are contraindicated, such as endothelin receptor antagonist, riociguat. During the pregnancy, we will have a multidisciplinary approach. We can use PPIs, histamine blockers, calcium channel blockers, low-dose aspirin. We can use corticosteroids at the minimum effective dosage. We will have to monitor closely the fetal growth, uterine activity, and uterine and umbilical arterial flows. We will have a strict monitoring of blood pressure and oxygen saturation, and we will treat aggressively in the event of hypertension. Using urgent biology, we will give priority to scleroderma renal crisis and preeclampsia, and consider differential diagnosis, and control blood pressure with authorized drugs. And in the event of resistance or a high probability of scleroderma renal crisis, we should use an ACE inhibitor as soon as possible. And we will monitor the risk of premature delivery. In conclusion, we have seen that we have quite reassuring data on fertility. We have a higher risk of intrauterine growth restriction, preterm birth, or perinatal morbid mortality, but we need more prospective and multi-center studies. Systemic sclerosis is generally stable during pregnancy, especially if the patient is carefully followed, and we will need a multidisciplinary approach. Of course, I recommend that you follow the national guidelines of your center. Thank you for your attention.